Anyone logged in? It was already on his screen. I'll just read out. Okay. You ready?
All right. Thanks, everyone, for coming tonight and joining us on the webinar. So we have Jess Smith, Daryl Manzer, and Michelle Dolphin talking about screening for pelvic floor dysfunction. Make sure that you have signed in out there if you're a member or a non-member. If you're a non-member, you can also pay before you leave if you're getting CEUs. And anyone that's getting CEUs has to fill out a course eval at the end, which we'll hand out from Amy. Should I have to press anything? Clip it to your shirt. Okay. So good evening, everyone. I'm just going to talk to you very briefly about this team of folks that you see up here, and then we'll get into content. So we are all actually alumni of Upstate Medical, and now I'm full-time faculty, and Jess and Daryl are adjunct faculty. They started coming into the program a few years ago in bits and pieces, and threaded throughout the curriculum, we introduced pelvic floor in kines, in our spine course, and then in greater depth, particularly related to pregnancy, in a course that was formerly known, like Prince, formerly known as Interventions 3, depending on when you went through our curriculum, if you did, and it's now called Advanced Therapeutic Activity and Exercise. And then 3 years ago, we developed an elective that's open to third-year students in our program, and we've had a really positive response to that. One of the things is just realizing that this is a specialty practice area, that many folks are not aware of that, so we'll address that tonight. But also, we've found some of our students are going on to specialize, taking post-professional courses. So we're really excited to be the team. Jess and Daryl are the content experts, and most of this will be executed by them. Can I just see a show of hands, folks here that are at least in the room? I'm sorry that I can't see you online. If you're working in this specialty area as well as pelvic floor, can you just raise your hand? Good. Hi, Jillian. So, Jillian, can you just tell us where you practice? Great. So as you're going through this content, or maybe you're somewhat aware of this content already, the way I look at it is like, if I didn't specialize in TMJ, who would I refer to help me manage that patient population? This is a good thing, that if you don't go on to further specialize your practice, who can you refer to for that advanced care when you need it? So we've got 3 in the house. Welcome.
Okay. I'm just wondering, how many of you in here have any exposure to pelvic floor physical therapy? Okay, good. So do any of you mind sharing what that exposure is or was? Uh-huh. Okay, good. Anybody else? Yep.
So in the setting I'm in, so we're getting lots of referrals now, which is nice, from, local gynecologists, obstetricians, mostly for incontinence.
Mm-hmm.
And so, I was fairly good. Like, I always tell them, try exercise first, we'll try adjusting these levels, and if it doesn't work, I'll have my surgery.
Yep, unfortunately they are. Anybody else have any exposure that they want to share? No? All right. So we're going to hopefully give you a little bit more exposure. I'm not sure how this is working. Sorry, guys.
Not a down arrow. Don't know. I'm the education expert. We don't want to do that every time.
Okay, anyway, what we're hoping to do tonight is explain a little bit about what pelvic floor physical therapy is, to explain some of the functions of the pelvic floor, to give you some relevance to take back to your practice, to discuss some of the evidence that supports that relevance, and then teach you how to screen for pelvic floor dysfunction, and then go through some case studies to summarize everything. Okay. So our objectives are tonight are that by the end of the night you'll be able to describe what pelvic floor physical therapy is, describe the functions of the pelvic floor, identify when the pelvic floor muscles might be contributing to lumbopelvic hip pain and dysfunction, and then identify when a patient may benefit from a referral to a pelvic floor specialist. This side? All right. Sorry about that, guys. For those of you who don't have any exposure, in pelvic floor physical therapy, we basically treat people who have urinary, bowel, and sexual dysfunction. So some of the common diagnoses that we see are urinary and bowel dysfunction, which might include urinary frequency, urgency, hesitancy, urinary incontinence, pain with urination, constipation, pain with bowel movements, difficulty evacuating stool. And then we also see a lot of people with pelvic pain, pain with intercourse, which is dyspareunia, and coccydynia or tailbone pain. So when these patients come into our office, we do what you would consider to be a typical orthopedic examination, where we take a look at the low back, the hips, the pelvis. But in addition to that history and examination that you're familiar with, we also will do internal assessment of the pelvic floor muscles. And this can be done either vaginally or rectally, depending on the diagnosis of the patient and depending on whether or not the patient is male or female. And one thing I want to point out right here, now that I'm talking about it, is a lot of people consider pelvic floor physical therapy to be women's health. And that's a misnomer that we're trying to get people away from, because pelvic floor dysfunction affects both males and females. And actually, in our clinic, 40% of our pelvic patients are males. So with this examination that we're doing, we're trying to determine are the pelvic floor muscles too short, too long, and are there maybe coordination issues that are going on with these muscles, and that then drives our treatment. Do any of you remember any of the muscles of the pelvic floor from gross anatomy? Anybody? Anybody remember oh, go. Yeah, I was going to say, that's the one everybody remembers, is the levator ani muscles. I think after school, I probably could have busted out the ischiocavernosus and maybe the levator ani. But don't worry, tonight we're not going to go into extreme detail with the anatomy. I'm just going to give you a brief overview and kind of explain to you how we explain to our patients when they come in. So when a patient comes in, we use this model. And I'll usually say, this is the model of the pelvis. It's a female model, but believe it or not, the muscles are pretty much the same in males and females. This is where the spine attaches to the pelvis. This is where the abdominals attach. And then all these muscles down here, what are referred to as pelvic floor muscles. There's a ton of them down there. There's 3 different layers of muscles, and they crisscross back and forth to form a sling in the bottom of the pelvis. This sling of muscles helps our organs to stay up where they're supposed to be, helps to give us core stability to protect the low back, and also gives sphincteric control over the urethra, the vagina, and the rectum. So the urethra, the vagina, and the rectum run right down through muscles like this. And that's how we explain to them what the pelvic floor muscles are, and then we go on to explain how those muscles might be impacting what their diagnosis is. For you, I'm going to break it down a little bit more, explain in a little bit more detail what the functions are. So on here, there are 4 different functions. The first function is supportive function. So the pelvic floor muscles are the only load-bearing muscles in the body, and they maintain a constant resting tone to create a shelf for the organs to rest on. So that's one supportive function. The other supportive function is that it works with the abdominal muscles to compress the abdominal cavity and fixate the trunk during extremity movement to aid in trunk stabilization. The second function up here that's listed is sphincteric, and I think that's pretty self-explanatory, right? So the muscles surround the urethra, the vagina, and the rectum, so they help to open and close these areas. And then sexual function. So the pelvic floor muscles help to maintain tone and support for the vaginal walls. They aid in proprioception for sexual appreciation. And in both males and females, these muscles help to maintain blood flow to the genitals during arousal. And a last function, which I wasn't even aware of until I was doing research for one of the courses we were doing, is there's a lymphatic function of the pelvic floor. The pelvic floor works with the diaphragm to create a mechanical pump that aids the lymphatic vessels and the venous sinuses in lymphatic drainage. So I know I threw a lot at you all at once on this one slide. Do you guys have any questions about any of the functions of the pelvic floor? No? Okay. Then we'll move on to talk about some of the causes of pelvic floor dysfunction. The first one on here is injury to muscles, but I'm going to make that a little bit broader category. Trauma is one of the main causes of pelvic floor dysfunction, and it can be trauma anywhere, but especially trauma to the abdomen and the pelvis, and this includes surgical trauma as well. Elective trauma is also trauma, and what happens when trauma is present is these muscles will activate and guard to try to protect as a protective response, and then they don't always relax afterwards when they're supposed to return to a relaxed state, and that can cause a lot of dysfunction. Certain visceral pain syndromes can lead to pelvic floor dysfunction. Are you guys familiar with interstitial cystitis? Yeah. So interstitial cystitis is an inflammation of the lining of the bladder that can lead to a lot of pain. And this will cause, again, the pelvic floor muscles to activate and can lead to a pain spasm cycle that persists. The same thing can happen with another visceral pain syndrome, endometriosis. Are you guys familiar with that one? Where the endometrial tissue starts growing outside of the uterus and causes pain that's usually cyclical in nature. And that causes the same thing. It can cause the pelvic floor muscles to guard and lead to a pain spasm cycle. Orthopedic impairment is up here, and I know that's a very broad, vague cause, but as we learn in school, that you have to take a look at the joints above and below. So the pelvis is here, anything up here, anything down here, how we move, different movement patterns, all play into how the pelvic floor works. Any asymmetrical movement through the pelvis can affect how the pelvic floor is functioning and activating. And we're going to break this down in a little bit more detail for you as we go through the presentation. We also have dysfunctional voiding and defecation up here. When do we learn how to use our pelvic floor muscles? Yeah, when we're potty training. Okay, so just like some people learn to throw a ball, and they learn to throw a ball really well, and some people don't learn how to throw a ball very well, there's people who just don't learn how to coordinate their pelvic floor muscles very well. And this dysfunctional pattern can persist throughout their life and can lead to pelvic floor dysfunction. And then up here, again, we have sexual abuse, but I'm going to say that any abuse, psychological, physical, but especially sexual abuse, because we see that a lot, can again cause that guarding pattern in the pelvic floor muscles, which can lead to dysfunction down the road. Any questions about that? Yep.
Where do you usually get referrals from? And like how knowledgeable are different types of providers on
Yeah, so most of our referrals come from urology and colorectal and also OBGYN. So those are probably our top 3 referral sources. And we're finding that certain physicians in the area are knowledgeable about it and have been educated on it. So those are the ones who are referring to us. But a large number of physicians are not aware of it at all. And nurses, I get a lot of patients who are nurses, and they say they've never even heard of it. So we're trying to do a lot of education in the community, both educating physicians and individuals in the community so that more people are aware of this so people can get help sooner. Does that answer your question? Okay. Yeah, of course.
clients who had trouble with potty training that you work with, or do you work with only involve a certain age?
Yeah, so I haven't worked with any pediatric patients yet. The youngest I've worked with is 12, and that was with tailbone injury, coccyx pain. but there is pediatric pelvic floor therapy. I just haven't gone and gotten trained yet for that. So down the road, that might be an area that I pursue, but it is out there, and we do know somebody in Lowville who treats pediatric patients. In that population, you do less internal work, and they'll use more surface EMG biofeedback. And that can be helpful with bedwetting and things like that.
And I think Tanya at the Bone and Joint Center is doing pediatric pelvic floor teaching now too.
Oh, good. Perfect. I'm thinking about it for sure. Any other questions? Okay. So one cause that I didn't specifically go into detail, because Dr. Dolphin is going to, is pain systems disorder.
I like you.
I know.
So I can barely talk about any topic in physical therapy these days without talking about pain. So they've granted me, I think, maybe 4 slides. I'll be brief. This one is just to recognize that pain really is an output, it's not an input. So when we have pain, it's a processing experience that occurs in our brain that's influenced by all different things, our biology, our personal history, our emotional state, our stress. I could go on and on with the list. But I think what I like about these 2 quotes, one is the reminder that there may not be actual tissue damage. It can be potential tissue damage or some concern about that damage. So it can become, without a clear injury, that you can have pain, and particularly when we think about the pelvis and all of the complex psychosocial issues around sexuality or around elimination. So just to recognize that here in our talk tonight. And then the quote by Lorimer Moseley, pain is to motivate us. So pain should be answered. It moves us to some action. So we're hoping that as we all gain greater awareness of helping patients in a variety of pain, that we understand that it's a motivating source for these individuals, and we have to acknowledge that and do our best to support them. And I'll tell you more about that shortly.
And I'm back. All right. Now, for those of you who don't have a burning desire to go out and get trained in pelvic floor dysfunction, we're going to talk about the relevance to your practice and what you might be able to bring back to your clinic. This slide is just basically a title slide for what we're going to talk about in the following slides. So the first thing we're going to talk about is trunk stabilization and just the relationship between the pelvic floor, the abdominals, the multifidi, and why you should be considering the pelvic floor when you work on trunk stabilization with your patients. Then we're going to discuss some of the referrals that warrant screening for pelvic floor dysfunction. So because of the location and the connection of all of these areas to the pelvis and the pelvic floor, any of these things could have a component of pelvic floor to it. So if you see these diagnoses, you might want to ask some of the screening questions we're going to talk to you about to see how much of the pelvic floor is involved. And we're going to highlight a few specific ones: low back pain, sciatic symptoms, and coccydynia, to give you a little bit more to go on. And then we're going to talk about pain referral patterns, because some of the referral patterns from the pelvic floor are to areas that you commonly treat. So we want to teach you how to recognize that. The first one, trunk stabilization. As I mentioned, the pelvic floor muscles work with the abdominals to fixate the trunk to aid in trunk stabilization. There's been a variety of EMG studies that have been done that show this relationship. This is just one of them to illustrate our point. In 2004, there was an EMG study where they found that with a maximum contraction of the pelvic floor muscles, there was simultaneous activation of the transversus abdominis, the oblique, and the rectus abdominis. So that is to support that this relationship is going on and they're working together. 2016, another article described the stability of the spine. And in this article, they say that the stability system is made up superiorly, I've got a laser here, superiorly of the diaphragm, inferiorly of the pelvic floor muscles, anteriorly of the transversus abdominis, and posteriorly of the multifidi. So again, evidence to support that the pelvic floor works with these muscles to create trunk stabilization. And if you are only focusing on the transversus abdominis and the multifidi when you're working on trunk stabilization, you're missing two key components of trunk stabilization. So we want you to be aware of that and tune into that with your patients. Say they're not getting better even though you've been working on trunk stabilization, you might be missing a huge part. Any questions on that? Yes, I don't have specific evidence here to say that, but we commonly use the transversus abdominis with our patients who are having a hard time finding their pelvic floor muscles. So I'll have them do a maximum contraction of their TA so that they start to feel the lift that happens down below, and sometimes that's enough feedback for them to learn how to activate those muscles. Any other questions? Okay. So then it comes as no surprise if the pelvic floor works as the main core stabilizer that it will be closely linked to the low back and low back pain. In an article published in 2008, they found that out of 200 women with low back pain, 78% had incontinence. So how many women do you treat with low back pain? A lot, right? So chances are you've worked with individuals who have pelvic floor dysfunction, and either they don't bring it up or you're not asking the right questions to see if the pelvic floor might be involved. Another article in 2010 found the presence of pelvic floor muscle dysfunction in individuals with low back pain compared to those without low back pain. So there is a close relationship between the low back and the pelvic floor, and when you're working with individuals who have low back issues, you should be considering the pelvic floor in your differential diagnosis. All right, now I just want to highlight coccydynia. How many of you have treated tailbone pain? Good, a couple of you. How many of you have treated tailbone pain successfully? Good, very good. I figured you would be raising your hand. So as you can see, tailbone pain isn't something that we get a lot of referrals for. And in our clinic, it was the same. But recently, we've started working with physicians, and we're getting a lot more referrals because we've shown we're able to help them treating the pelvic floor. So we're giving you this article so that if you get a patient who comes in with tailbone pain, you have some guidelines to go on. And I'm just going to briefly run through a summary of what it is and then explain how we treat tailbone pain so you have a better idea. So the functions of the coccyx are to be an insertion site for muscles, ligaments, and tendons, but it also works with the ischial tuberosities to provide weight-bearing support in sitting. The tailbone is most commonly injured through trauma, usually with falls or during childbirth, but it can also be caused by microtrauma with repetitive sitting. And individuals who have tailbone pain will say that they have with prolonged sitting. They have pain with sacral sitting or sitting back on the tailbone, and they'll also have pain with rising from a seated position. Yeah. Oh, sure. Hang on a sec. I'm going to interrupt this broadcast for those people that are at home. Could you please mute your phone? All right, and we're back again. Okay, so in your physical examination, you might find that there's tenderness over the coccyx, and it's important to know that 90% of people with tailbone pain will get better with conservative treatment, and a lot of people get better on their own without any treatment at all. But for those who do need treatment, they recommend pelvic floor rehabilitation, manual manipulation of the coccyx, massage, coccyx cushion, and NSAIDs. Does anybody have any questions about that brief summary? Yep. I don't have that specific number. It wasn't in the article. They just said that 90% improve with conservative treatment and that a large portion of them improve on their own. Yep. Any other questions? Okay. So I'm just going to explain a little bit. We talked about how the tailbone is a major muscle attachment site. You can see all of the muscles that come in and attach on the tailbone. So frequently what happens with trauma to the tailbone, either in this direction from a fall or this direction with childbirth, is the tailbone is getting moved beyond where it should be moving, okay? And the muscles that attach to the tailbone are going to activate to try to stabilize it and prevent it from moving too far. And in the people who get better on their own, those muscles will calm down, they'll relax, and the pain will go away. But in the people that we're seeing, what I'm finding is that these muscles aren't relaxing on their own. And so what I'm doing is some manual release of the glute muscles, some internal trigger point release to these pelvic floor muscles right near the tailbone, and sometimes some manipulation of the coccyx itself, depending on if it's too far flexed or whatever. So that's what we're doing to treat tailbone pain. You guys can work on the glutes because there are glute attachments on the tailbone, which is mentioned in the article that we have referenced for you. So you can release the glutes. And I had a 12-year-old one time where we released the glutes, and she almost completely resolved her tailbone pain. So if you work on the glutes, that's a place to start. And then if they're still not getting better, you might want to consider referring them out. Any questions on coccydynia specifically? Yeah. Yeah, so usually the fracture will heal. And most of the time, I've treated a lot of people who have old fractures. And what the physicians will do, they'll see the fracture on the x-ray, and they'll just tell them, you know, you just have to deal with it until it heals. But then people are finding after the 6 to 8 weeks when it should be healed that they're still having a lot of pain. And at that point, it's no longer the tailbone itself. It's these muscles that are overactivated. And so what we can do is get those muscles to relax and relieve their pain. We also do a lot of patient education and then training of those muscles to get them to relax. So doing a lot of diaphragmatic breathing to teach them how to drop their pelvic floor muscles, and coordination training to learn where those muscles are, how high they're resting, and how to get them back down to a normal resting length. Yep. In the article, I believe they do go through a few modalities, so I can look that up for you and talk with you after if you want. I don't tend to use a lot of modalities with this because I don't find that there's a lot of evidence for it, but I think some of the modalities you probably could. I don't know what results you would get. Any other questions? Yep. Okay. Yep, sure. Sorry, guys. I will repeat the questions before I answer them. Any other questions? Okay. Then I'm actually going to hand this over to Dr. Smith.
Thank you. Gotta go on. Right. Hi, guys. So in addition to coccydynia, I'm going to talk about other referrals that might warrant screening for pelvic floor dysfunction. So those are going to include piriformis syndrome or sciatica. And what we're looking at specifically as pelvic floor physical therapists is the obturator internus muscle. Does everyone remember this muscle from anatomy? Yeah, okay. So its function is it's an external rotator of the hip, but it's actually best palpated internally in the lateral wall of the pelvic floor. I don't know if you guys can see that there. Okay. So the obturator internus and the piriformis essentially sandwich the sciatic nerve. So restrictions in the obturator internus can cause sciatic symptoms or posterior thigh pain. And sometimes that's misdiagnosed as piriformis syndrome. So the obturator internus is something else that you want to consider in that differential diagnosis. And then, as Daryl mentioned earlier, I'm going to talk about specific pain referral patterns in this area. So a journal
of Obstetrics and Gynecology quoted that patients with pelvic pain from musculoskeletal disorders describe their symptoms of low back pain, gluteal, groin, or leg pain, but they may not offer their symptoms of vaginal, rectal, or lower abdominal pain. And then another article quoted that myofascial pelvic pain is a frequently unrecognized and untreated component of chronic pelvic pain. So it's important for us as physical therapists to be able to screen for pelvic floor issues because a lot of times it's going unnoticed and there's a lot of patients that need help in this area. So these are kind of hard to see, but one of our references by Pastor and Katzman is a really good resource for pain referral patterns in this area of the body. So if you guys want to write down the name of this article to look up, it's Recognizing Myofascial Pain in the Female Patient with Chronic Pelvic Pain. But of course that can apply to males too. Do you guys need me to repeat that? Okay, so it's Recognizing Myofascial Pain in the Female Patient with Chronic Pelvic Pain. And the authors are Pastor and Katzman. So you can find these referral charts in there if you want to look at them in more detail. I'm not going to go through every single one, but I'm going to highlight a few. So the first being the coccygeus and the levator ani muscle group. So those muscles you can see here. Okay, can you guys see them? All right. And they attach to the coccyx. So trigger points in these muscles or hypertonicity in these muscles can cause pain in the sacrococcygeal area as well as buttock pain. So those are symptoms that you guys might get referrals for and symptoms that patients are going to readily offer to you. But they might also have pain with intercourse, urinary urgency, frequency, leakage. They might have pain with bowel movements, constipation, or difficulty moving their bowels. And a lot of times patients aren't readily going to offer that information to you. And then another pain referral pattern that we want to talk about that kind of shows the relationship the other way. So you guys are used to working with the TA and the obliques, but these muscles can actually cause pelvic pain. So they can refer pain to the groin, the genitals, and they can cause lower quadrant abdominal pain. And sometimes they can cause urinary urgency and frequency as well. So a lot of times we think of these muscles from the standpoint of needing to strengthen them, but keep in mind they can also be a source of pain. And then again, coming back to that obturator internus muscle, so in addition to sciatic symptoms or posterior thigh pain, the obturator internus can also cause anal pain, coccyx pain, and again, pain in the genitals. Questions on any of those? Okay. So since you guys aren't going to be doing internal exams on your patients, and you're probably happy about that, most of you. So we'll talk about how you can screen for pelvic floor dysfunction through your subjective information and through some of the external exam. So even before you see a patient, there might be things on their intake forms that are going to make kind of clue you into the possibility of pelvic floor dysfunction. So really any abdominal or pelvic surgery, like Daryl mentioned before, they might check boxes for urinary or bowel symptoms. Maybe they have a history of pregnancy, which is very common. Endometriosis, as Daryl mentioned before. Infections, especially repeated UTIs or vaginal infections, can either be a sign of pelvic floor dysfunction or a risk factor for it. And then again, any kind of trauma, such as a fall on the coccyx or, again, a history of abuse, unfortunately. Yes? Yeah. Yes. The question was, do we include some kind of form asking the patient about their history of trauma, since they might not offer that or really know what we mean? We don't. We usually ask it when we're talking with the patient, but it probably would be a good idea to include that. Right. And then symptoms, again, that patients might offer to you are low back pain, tailbone pain, SI pain, back pain, hip pain, sciatic symptoms, groin pain, or lower quadrant abdominal pain. So like Daryl mentioned earlier, if a patient has any of these symptoms, screen for pelvic floor dysfunction. A lot of times, if the pelvic floor is involved, particularly if there's trigger points or hypertonicity there, patients are going to say that the symptoms are better with heat or a warm bath and rest, and that aggravating activities, a huge one is prolonged sitting. Lifting might aggravate the symptoms, exercise or activity. And then in this population, a lot of patients even recognize that stress increases their symptoms. So I'm sure you guys all see tension being held in neck muscles. People also hold their tension in the pelvic floor. So some people are walking around all day doing a Kegel, and they have no idea, and it's no wonder that they have pelvic pain. Okay. And then sometimes, too, the symptoms may fluctuate with changes throughout the menstrual cycle. All right, so through your subjective exam so far, you might be thinking about pelvic floor dysfunction. So what are some screening questions that you guys might ask? No one wants to say it ever. Yeah. Yep. So the answer was, are they having any issues with incontinence? Other ideas? Yeah. Yeah, good. Somebody said that, ask the patient if they've been taking any medications, such as diuretics that could increase urinary frequency. Other ideas? Yeah. Yep. So the answer was, is there any sexual dysfunction or a history of sexual abuse? So asking about pain with intercourse. Other questions? All right, so you could ask about bowel movements if there's any pain, constipation, or do they have to strain? And then I think you guys hit on the other big ones. And sometimes these things can kind of be hard to talk about for both the therapist and the patient. And sometimes patients are going to think you're nuts if they're coming in for low back pain and all of a sudden you start asking, do you have pain with intercourse? So usually the way around that, and a lot of times people ask us, well, how do we make that transition, is we'll educate the patients on the pelvic floor muscles. So we'll use the model, but you guys could use a diagram in the clinic. And once you explain the muscles to the patient, a light bulb usually kind of goes off and they'll open up with a lot of information and it really makes sense to them. So don't be afraid to ask. Back to you, Michelle.
So just a little bit more about looking at when maybe a more comprehensive approach to a pain problem with a patient with a pelvic floor disorder might be indicated. So what I'm talking about here is persistent pain that we might call chronic, but where a sensitized nervous system is really creating havoc for the patient. So on this slide from an article that we've used in the elective, these may be some indicators. So when you have sort of spreading pain, or when you have where normal touch causes pain, those would be abnormal findings in someone that might suggest a sensitized nervous system. When you have pain beyond that normal tissue healing, and this is even longer than what you might guess at first, maybe 6 to 8 weeks, maybe 10, maybe 12, we would think by this point, 12 to 16 weeks, if it's soft tissue only, it would have healed. And even if it was a fracture in a healthy individual, it should have healed. So when you see pain persisting, there may still be muscles to treat, but there's probably also an entire person, an entire nervous system to help manage. Some other yellow flags that can be considered when you're trying to decide and how comprehensive your educational approach will be with the patient is certainly if they have other issues of depression, anxiety, fear, and then those histories of abuse. Are they in a safe situation now? What are all the other factors that may be going on in their life? So this is just a reference point. We've shared with our students in electives, and I've shared with patients, this handbook from Adrian Lowe. It's Why Pelvic Pain Hurts, and I brought some of his other little booklets. These are sort of in the genre of treat your own back, but it goes through the process of de-educating the patient first before you try to find some real deep cognitive learning in individuals. And the example I share with students is if tomorrow my thumb starts hurting in the new academic building, I'll look at my thumb, I'll move my thumb around, I'll go down the hall to my colleagues and say, hey, has your thumb ever hurt like this? So when it's your pelvic floor, you don't do that. So people have this history of kind of keeping it hidden. They may be ashamed. It may be difficult, which can push this time frame out and, again, sensitize or heighten their nervous system response. So just keeping that perspective in mind, I think, is really helpful. Questions here? So just a couple slides, again, not the great detail because it's not the focus of our time together tonight, but just kind of reminders of things that maybe you're training in or you're learning about. When we want to downregulate the central nervous system, we're looking at a real varied approach. If you can start with a patient's values or preferences, they want to get back to walking. They would like to get back to yoga and use that as a connection. I sell exercise in a different way. I trained as an exercise physiologist first before becoming a PT. Now I sell exercise as the endorphin machine. That's the way to make me feel good. If I can get you to start walking, to get on a bike if it doesn't hurt to sit on a bicycle, to get in some water, to do some movement that will help you, rent funny videos or pull them up online. Nobody's renting videos anymore. Doing some deep breathing, some relaxation, lots and lots of ways of bringing that tone down in the nervous system. And then NOI stands for the Neuro-Orthopedic Institute, and they've got a lot of great things that patients can access for free, which is important, resources and things that they can learn. If you type in NOI, you might get Nation of Islam, which is fine if you're looking for that, but if you're not, it's the Neuro-Orthopedic Institute that you're looking for this resource. And just one more slide, how do we get this done? This is really hard work. And my students will say, and you charge for that? You charge for listening to someone and educating someone? Yes, I do. It may be a little tricky sometimes, but if I'm talking about how to adapt exercise, how to do deep breathing, I bill it as Therex. If my hands are on the patient and I'm teaching them diaphragmatic breathing or relaxation exercise, I might call it manual therapy. There are ways to account for your skilled care. Patients need your skills and your orientation to the sensitivity of the nervous system to really help manage what's going on with them. So just a list of resources and references. There's so much to learn, but hopefully this will just remind you of this aspect, particularly with pelvic pain. Questions? Onward.
Yeah, got it. Just hold it this time. All right. So once you've gotten through all of the subjective information for screening for pelvic floor dysfunction, as well as pain systems disorders, there are some things in the external exam that might clue you into pelvic floor dysfunction as well. So oftentimes, patients who have hypertonicity in the pelvic floor, a lot of times will also see soft tissue restrictions in the iliopsoas, the abdominals, and the hip adductors. And oftentimes that's because patients tend to kind of come in this guarded pattern to protect that area. And those, of course, are all areas that you guys can treat externally. As Daryl mentioned earlier, sometimes there's restrictions in the glute muscles and the piriformis as well, especially those patients presenting with coccydynia. And a lot of times we'll see restrictions in the QL. And then another thing that you guys can assess is abdominal scar mobility from any pelvic or abdominal surgery. Because of the fascial connections between the abdominal muscles and the pelvic floor, if there's any restriction in the abdominal area, that can contribute to pelvic floor hypertonicity, so it essentially draws the pelvic floor upwards. So working on those scars can help with pelvic pain or any of the other symptoms of pelvic floor dysfunction. And then while you're looking at the abdominal area, another thing you can assess for is diastasis rectus abdominis. How many people do this pretty regularly with patients who have been pregnant? Yeah, I think a lot of times it gets forgotten outside of the world of women's and men's health therapy. So that's another important thing that you can quickly assess for that can, of course, significantly impact patients' core stabilization. Questions on any of that? No? Okay. All right, so now we're just going to go through a couple of cases to help summarize. The first case I'm going to talk about is a 60-year-old woman who was referred to one of my colleagues for low back pain. And when she came in, he was asking her, performing a regular history, and when he asked where the location of her pain was, she said that it was more in her tailbone. And because he works with 4 pelvic floor therapists, he asked further questions and asked if she had any issues with her bowel function or her urinary function. And she said, yeah, actually, I've had a lot of issues with those things. And since I was right across the hall, he just said, wait here for a second. He went over, grabbed me, and said, would you mind taking a look at her? He's like, I don't think this is going to be in my area. So when I went in and I asked more about her history, I found out that she had had tailbone pain for 10 plus years, and that the pain ranged from 0 to 10 out of 10. With ibuprofen, she could get it down to 0 out of 10, but without medication, by the end of the day, it would ramp up to 10 out of 10. Her surgical history, she had a total hysterectomy, sinus surgery, cataract surgery, and also gastric bypass surgery in 2016. She had some allergies, a GIST sarcoma, which I had to look up. It's a tumor in the GI tract, and pulmonary hypertension, and MS. Up until the point of seeing us, she had seen a chiropractor and a massage therapist, and she hadn't had any relief yet. She described her functional limitations as being with stairs, walking, and bending, and she rated all of these as a 6 out of 10 on the patient-specific functional scale, which I'm not sure if you're familiar with it, but would mean she was about 40% limited with these activities. When I started asking some of the follow-up questions, she said that she had had urinary symptoms for 5 years, and she said that those symptoms were urinary frequency, urgency, urinary incontinence, and also a history of frequent urinary tract infections. She said that she had had constipation for over 20 years, and that recently in the past few years, she had started noticing some pain with intercourse. When I did my physical exam, I found increased tissue tension in the glutes and in the pelvic floor muscles interrectally, and also that she had a really difficult time relaxing those muscles. So when you go internally, you can get a feel for how high the pelvic floor is resting. It should be resting down here like this, but in a lot of people who have pelvic floor dysfunction, it'll be resting up here like that. And that's what I found with her. So yes. They should be able to, yes. But a number of them, what do? They put a speculum in, they push the muscles out of the way, and they don't even really assess the muscles. There are a select few that have been trained and will do that, but a huge portion of them are missing this. And a lot of times they just say, oh, you're getting older, it's normal, wear a panty liner. That's what a lot of people get, unfortunately. And it is a common misconception that as you get older, it's normal for you to be leaking. That's not the case. I've treated women all the way in their 90s for incontinence and been able to get them better. So I treated this patient for several weeks, doing external manual release to the glutes, doing internal coccygeus release rectally, and also teaching her how some down training to relax those muscles, doing some diaphragmatic breathing, some coordination training, and we also started her in a yoga class that we're offering at our clinic for our patients with pelvic pain so that she could learn to coordinate those muscles with different functional activities. And she participated in that, and then at one point she called the office and canceled the rest of her appointments, said she was feeling great. Do you guys have any questions? Yep. Yeah, so the question was, how do I distinguish when the pelvic floor muscles are elevated when I do an internal exam? So a lot of it is you just get used to the feel of it. You know how we all started out in our massage class and we're trying to figure out what's normal tissue, what's not normal tissue. So some of it is experience, but you can also tell externally. So if you look at the perineum, the patient's lying down, you look like this, you should be able to see everything flat. You should be able to see the vagina, the rectum, and the area between, which is the perineal body area. You should be able to see all of it. For individuals who their pelvic floor is pulled up, you'll see that that area between the vagina and the rectum is pulled up and in, and you can't really see it. And so when I go in, some of it is how far do I have to go before I reach the shelf that's inside, and if I have to go really far in order to reach that, I can tell that the entire pelvic floor is elevated and pulled up. Yep. So the question was, how would you tell with men? And it's the same thing for males. So with males, in their initial examination, I'll do an external assessment of the ischiocavernosus and the bulbocavernosus, which are these muscles right here. And how I do that is I have the patient sling under their penis and testicles, hold them up out of the way, and then I just poke underneath at all of those muscles and see, well, palpate, I guess. Poke isn't really. We'll be professional here. So I palpate those muscles externally, and then while I'm there, I can also release some of those muscles, and then I'll do an internal rectal exam where I can see what's happening more with the posterior muscles of the pelvic floor. And it's the same thing. When you go in, you can tell if it's elevated. You can tell the sphincter tone by how tight it is around your finger. And as you work with individuals, you get a feel for what's normal and what's not. Any other questions? All right, then we'll move on to another case.
Thank you. All right, so another case that I had recently was a 65-year-old female who was referred to our clinic with buttock pain, and she wasn't referred to our clinic specifically because we treat pelvic floor dysfunction. She just kind of happened to end up at our practice. And she described left buttock pain around the ischial tuberosity. It was an insidious onset. The pain levels were between 0 and 8 out of 10, and it was worsened with prolonged sitting. And she denied any low back pain or distal symptoms. Her medical history here was really nothing significant to report to you guys. And again, her main functional limitation was she could not sit prolonged periods. When I asked her some pelvic floor follow-up questions, she said that since the onset of the pain, she did start to notice some difficulty moving her bowels and increased constipation. And of course, I went through the full external exam, didn't really find anything major except some tenderness through the gluteal muscles on the left side. And I also checked internally, and she had trigger points in the obturator internus and levator ani muscles that reproduced her symptoms. And then for a few weeks, we worked on internal trigger point release of these muscles, as well as some down training of the pelvic floor and different stretches and yoga postures to open up those muscles. and her symptoms were abolished, including the constipation and difficulty moving her bowel. So we just wanted to give you guys some real-life examples of patients who weren't necessarily referred for pelvic floor PT, but sort of ended up needing it. So we wanted to say thanks for coming and listening to us talk about bowel movements and urination and vaginas, and thanks for sitting through that. Do you guys have any questions at all or any cases that you want to share? Yeah. Sort of a basic one. So when you're in a squat position, the pelvic floor is in a relaxed position. I don't know if you guys have heard of the squatty potty. So it's basically the squatty potty puts the pelvic floor muscles in a better position, so you get a little bit straighter shot for the stool to come out. So working in squatting positions, so doing things like, if you're familiar with happy baby or child's pose, or we'll do a lot with yoga postures to work with diaphragmatic breathing through the movements, because like we mentioned before, a lot of these patients are walking around doing a Kegel all day long, and they don't know how to do anything without activating the pelvic floor. So we'll use diaphragmatic breathing with movement patterns to teach them how to relax those muscles as they're moving. So yoga's great for that, but any of the squatting positions relax the muscles. Yes?
So how do you go about teaching males and females this Kegel? So that position way some of the key things are different.
Yeah. Sure. So the question was, how do we go about teaching how to do a Kegel properly, and what would a home exercise program look like? So patients that we would teach Kegel exercises to, of course, would be patients who just have lengthened and weak muscles. We don't do the Kegels with patients who have any hypertonicity there. So usually we're palpating internally, and we'll ask the patient to squeeze like you're stopping the flow of urine or stopping the flow of gas, and we'll assess how the patient's able to squeeze. And we do have a grading system, 0 to 5, just like other muscles in the body. We say 0 is pretty much, if you ask them to squeeze, nothing's happening around your finger. 5 is pretty much, give me back my finger. You can't really get it out. Okay. Most people don't reach a 5. You don't really need to be a 5. I know, everyone's going to be like. And then, so that's how we'll cue them to do it and assess how well they're doing it. And then the way that we teach Kegels is we're usually palpating internally, so vaginally for females, rectally for males. And we'll again coordinate that with the breathing. So I'll usually say to the patient, take a deep breath in through your belly. As you exhale, let the air out, draw your belly in, and squeeze like you're stopping the flow of urine. So that's usually how we instruct them. A lot of times if they're not coordinating it with the breathing, they're doing a Valsalva, so they'll go and try to do a Kegel, but then you're just creating intra-abdominal pressure, which is going to cause more leakage, so you're sort of fighting against yourself. And then other times, if we don't cue them with the breath, they're not relaxing fully in between, so they're creating some insufficiency there because they need to work through the whole length of the muscle. Does that answer your question? Okay. Yeah. Or did you have, yeah, go ahead. Yeah, you can go ahead. We, in our practice, tend to see more issues with hypertonicity. I don't know if that's really more the prevalence in the general population. I think we tend to see more hypertonicity because those patients can't really get themselves better. If there's just weakness, a lot of times patients will try doing Kegels or their doctor will recommend it, and maybe they'll improve. So we definitely tend to see a lot more hypertonicity, and I think it's just for that reason. But good question. Yes? That's a good question. Can everyone at home see that question posted? Okay. All right, so I don't have to repeat it. So usually our referrals are coming from colorectal surgeons if the issue is constipation. So typically other sources have been ruled out. And then assessing the muscles. So if we're not finding any muscular reason for constipation, then we might want to think about other causes of it. Do you have anything to add to that?
No.
Nope. Okay. All right. Yes.
You talked about sciatic pain often being misdiagnosed as piriformis and really involving observation.
Yes.
I'm wondering if there's a way that you can make that differentiation in an external exam anyway.
Yes. So that's a good question. The question was, since we talked about how the obturator internus can cause sciatic symptoms that can be misdiagnosed as piriformis syndrome, is there a way to externally make that differential diagnosis? So a lot of times we'll do that palpation externally. So we can palpate the piriformis, and then the obturator internus is most easily palpated internally, but you can palpate it if you find the ischial tuberosity and then sort of scoop in medially. We'll have Daryl demonstrate here.
Okay, so the obturator internus is located right here. So you have the patient lie on their side with the bottom leg extended, top leg bent. And what you do is you push the glutes out of the way, and then with a flat hand, you can push down towards the ischial tuberosity, and you can palpate the obturator internus. So if you palpate this and it reproduces the patient's symptoms, or if they're like, oh, that's really tender, then that could be involved in what's going on. Does that make sense?
Okay. And you'll kind of feel like you're almost dropping off a shelf there to get into the muscle. And then a lot of times students ask, well, how do I know if I'm on it? We'll just tell them to have the patient rotate the hip actively, and then you'll have a better sense if you're on that muscle. And then since it's also an external rotator of the hip, any stretches into internal rotation you could do as well to help. Yeah. Yes?
There are general pain charts and your chart taking some of the symptoms. Are there any specific pain charts that are more along pelvic genital areas?
Pain charts in terms of like posters or questionnaires that we would ask the patient? Oh, yes. Yeah, we don't have any that are necessarily specific to the pelvic floor. The question was, do we have specific pain charts for this area? We usually use the ones that you typically would and have the patient fill it out. But there is the vulvar functional pain questionnaire that will have patients fill out in addition to that. And that asks about pain with intercourse, pain with bowel movements, pelvic pain. Any other? Yeah.
What typically are you doing to downtrain the pelvic floor?
Yeah. So the biggest intervention we use. Oh, I got to repeat the question. The question was, what interventions do we use to downtrain the pelvic floor? So the biggest one is diaphragmatic breathing. So as you're inhaling and the diaphragm contracts, it creates a gentle downward pressure, so the pelvic floor drops. So I describe it to patients as it's kind of a reverse Kegel. We'll also teach patients to push along with that movement. So as they inhale, we'll say gently push like you're trying to pass gas. And then, like I mentioned earlier, we'll use a lot of yoga postures or positions to help open up the pelvic floor. So like we said, squatting positions, so that could be child's pose, happy baby, squatting in general. And then exercises into abduction, too, will help open the pelvic floor. And then another big thing we're doing is internal release of the trigger points, of course. Other questions? Yeah.
I was working with a pretty significant softness
Yeah.
that he developed after an abdominal surgery.
Yeah.
During his time that we were working with him, he developed incontinence, and I suggested to him that he might want to look into pelvic floor treatment.
Yeah.
Like this, he was pretty thoroughly funded.
Yeah.
So as an outpatient physical therapist, considering his condition, are there any interventions you might suggest to treat that?
Without internal work? Yeah. So the question was, someone had a patient on clinic who, it was a male that developed incontinence, and she had talked to him about pursuing pelvic floor therapy, but he was very resistant to that. So what are some interventions that she could instruct him in, just externally without doing anything internally? So we're usually hesitant to recommend doing pelvic floor strengthening if we're not sure if the patient has shortened muscles or just lengthened and weak muscles. But you could try having him do some belly breathing along with instructing him in a Kegel. And if things got worse, maybe there's an issue of hypertonicity, or maybe it'll get better if it's just an issue of weakness. And, and then I was going to say I did not address your question of what a home program might look like earlier that could go along with that. Based on the strength grade, if a 3 out of 5 in floor strength, we want to start them with supine exercise or even gravity assisted with the hips up, and then standing. So if that patient is really resisting anything internal, you might want to start them supine as well, just because you're not sure what grade they are, and then try progressing up.
Okay, so back to the question about the diastasis rectus abdominis and then incontinence. A lot of times individuals who develop diastasis rectus abdominis, especially if they haven't been pregnant, it's usually caused by an increase in intra-abdominal pressure. So these individuals usually have a very difficult time controlling the pressure in their abdomen. So what you can do is watch how they're moving. If they go to get up off the table and they're grunting, they go to stand up and they're valsalving with every movement they do. A lot of times if you just bring it up to them, they'll be like, oh yeah, I am holding my breath with everything that I do. And if you ask when they're incontinent, it'll usually be when they're standing up out of a chair, when they go to bend over to pick up something off the floor, all the times when that pressure is increased. Okay, so one thing you could work with them on, and that's sometimes where I start with these guys anyway without doing any internal work, is teach them how to coordinate their breathing and control their intra-abdominal pressure without performing a Valsalva. So I'll have them practice first lying down where it's easier to control the muscles. I'll have them breathe in, make a big belly, and then on the exhale, draw their abdominals in so that they're activating their abdominals without holding their breath. And then I'll have them try to hold that, but without holding their breath. I'll have them breathe shallowly, and then I'll just have them keep working on that. Breathe in, big belly, breathe out, pull it in. And once they learn how to coordinate that, then I have them practice it with sit-to-stands, with getting up off the table, with bending over, with squatting to lift. So I train them with all the functional activities on how to control that intra-abdominal pressure. Yep. Yeah, so the question is, for individuals who have hypertonicity in their pelvic floor muscles, what else can you do other than internal trigger point release? So a lot of times, if I'm working with somebody and they're not comfortable with me doing internal work, I'll do an external assessment of all those muscles that Jess talked about, the hip flexors, the adductors, the glutes. And a lot of times you can start there, because if people are hypertonic here, chances are they're hypertonic in a lot of those muscles too. So I'll start with some hip flexor stretches, some adductor stretches, some glute stretches to try to open up the hips and also get the pelvic floor to relax a little bit. Then I would teach them how to do diaphragmatic breathing. If you look at how people are breathing, a lot of people are chest breathing. So they're breathing, you ask them to inhale and they it comes from here. They don't know how to use their diaphragm. So you can say, all right, breathe in, big belly. Now, can you feel any drop down in your pelvic floor? Do you feel the muscles relax? So you can teach them how to do diaphragmatic breathing, and then you can do some of the yoga poses that Jess was talking about. We're not designed to go to the bathroom in sitting on a toilet. We're designed to go in a deep squat. So if you can get them down into a deep squat and have them do some breathing, sometimes that will help the pelvic floor drop. Or if their knees or hips or whatever can't handle a deep squat, you can have them get into child's pose and have them do some diaphragmatic breathing, because that's basically a deep squat just flipped over on their stomach. And so the pelvic floor muscles will already drop a little bit. And then if they incorporate the breathing there, I say to my patients, you get a little bit more bang for your buck because the pelvic floor muscles are already dropped, and then you're stretching them further with the breathing. So those are some things you could start with, see if you can get things to start calming down. And then if you're not having success, then maybe refer to somebody who can do the internal work. Yes? The question is there a clinical practice guideline for pelvic floor dysfunction? Not that I'm aware of. Do you know of one? No, there are some good summary articles. One reference article that we have for you, where's our references here? The recognition of non-relaxing pelvic floor dysfunction. Yeah, so there's an article that's on our references, Recognition and Management of Non-Relaxing Pelvic Floor Dysfunction from the Mayo Clinic Proceedings by Fabian and Schuster in 2012. We put that one in here because it's a great summary of, it's actually written for primary care physicians, to be able to recognize when the pelvic floor is involved. It tells you what questions to ask, how to perform an internal exam. It's a really good summary, and I would start there if you wanted to look at an article. Any other questions? Yep. Yes. So right up here, it's this article right here. Recognition and Management of Non-Relaxing Pelvic Floor Dysfunction, Mayo Clinic Proceedings, 2012. And is this presentation available to everybody afterwards too? Oh, okay. All right. Gotcha. Any other questions? Yes.
I'm interested in knowing the path of education that you went through to specialize in the practice that you're currently doing.
Yes. So both Jess and I have taken the courses from the Herman and Wallace Institute. And Jillian, I think that's where you went to, right? That's the place that we recommend people go through. We found that their classes are excellent. And when I refer patients who are going to other cities, I suggest that they see a therapist who have taken those courses. So if you go to the Herman and Wallace Institute online, there's a whole host of continuing ed courses related to this. And you start with, I don't know what it's called now.
It's called Pelvic Floor 1 is the first one that you would start with.
I don't know why I can remember that.
And then there's Pelvic Floor 2A, 2B, and it goes back. Don't start with 2. But those courses are usually like 3 days. The more introductory ones are 3 days. And then after that, you're good to go and get right in there. But we always, literally, no. But we always tell students that are interested or other therapists that it's kind of hard to go to a 3-day course and then come back and all of a sudden be doing this, because it can be a little bit intimidating just because of the area of the body. So we always recommend trying to develop some kind of mentorship. So Daryl was my mentor, and then sometimes people from other, like we've had students who are now in Buffalo who will call us with questions. So I think that's an important aspect if you do end up getting into this area, to develop a mentor. Yeah, which we're always happy to do for you.
Is most of your caseload pelvic floor patients at this point, or, I mean, how much is there in the area?
There's a huge need. We have 2 therapists in our practice whose caseloads are almost 100%. And then there's 2 of us that are kind of 50-50 with general orthopedics, but that fluctuates. And sometimes we'll have a waiting list. And I don't know about the 3 girls at Upstate, Jillian. Or... So you're part-time, but that part-time is 100%. Yeah, but I think there's a huge need for it. Yeah. Any other questions?
I started working on a survey that I didn't finish in time for this meeting, but I'm hoping to send out to Central District. As part of Upstate's commitment to post-professional education, we're considering developing a 1-day post-professional course to be held here in Syracuse that would not include internal examination, because it's with your friends and neighbors. It can be a little more disconcerting, but would help you to better recognize, perhaps managing the obturator, externus, and internus, and all of these muscles that we think, wait, where are those again? So examination, case-based conversation, and intervention that we think we could do pretty well in 1 day. So hopefully if you have that interest and you want to take a course here in the community and then decide, okay, I'm going to continue on and do more advanced skill training, we hope to do a survey out to all of you to see if you're interested before we build it, and then we'll stay tuned. So from the interest tonight, that's kind of exciting. Lots of people to help.
All right, any other questions? All right, great. Thank you guys very much.
And if you guys want to, you can feel free to contact us with any questions. The number at our clinic, if you want to write it down, is 699-1009. 699-1009. And we're at Moro Bertolo Therapy in Cicero, so we're always happy to answer questions, okay?
So those of you that are members to get your CEU credits, I need to have one of these filled out. For those that are not members,